Thank you for joining us today on this episode of The Cancer Project. We're really privileged to have Dr. John Chang, Medical Director of the Oklahoma Proton Center, back for part 2 of a conversation with an oncologist. And today, we are going to answer the questions that you've always wanted to ask an oncologist. So we've compiled a list of questions that our patients have asked as they've come to the center, and we hope that those are going to be really helpful and educational for you. So again, questions you've always wanted to ask an oncologist with Dr. John Chang, Medical Director of the Oklahoma Proton Center. So here we go. We're gonna dive right in. So one of the disease sites that we treat pretty frequently at the Proton Center is breast cancer. And one of the questions that we get asked a lot is, can I do proton therapy and not do surgery or chemotherapy? So for that type of question, how do you approach answering that question?
Well, what I usually tell them is that when you get a diagnosis of breast cancer, usually the surgeon, the oncologist, and the radiation oncologist usually all kind of convene and talk about the patient approach because it is really a tri-modality, or all three medical disciplines really need to weigh in on what the best approach is. To really kind of address that question, it is very dependent on what the cancer is, the extent of it is, to know how much surgery they need, whether they need chemotherapy or hormone therapy, and where radiation plays a role. Just as a generic answer to that question, typically radiation cannot substitute for surgery. Mm-hmm. And if chemotherapy is needed, radiation usually cannot substitute for that, because surgery is something that removes the bulk of the cancer, and then chemotherapy kind of treats the whole body. And so radiation is really focused on the cancer in the breast, and we typically want the surgeon to remove as much of it as possible. So when the radiation hits it, the area that's left is hopefully just microscopic cancer cells, and that's where we're going to be most effective for breast cancer.
So for a breast cancer patient, they're getting radiation. Another question we get is, why would I get proton therapy versus photon therapy? Isn't radiation?
Yeah, from the standpoint of killing the cancer, the protons and the regular radiation photons is similar in its ability to kill the cancer. The difference is that when you use regular radiation, it's just a beam of energy. So when we shoot it into the body, it goes in one side and out through the other. Protons are like tiny little bullets or tiny little particles that we send in, goes to a spot, hits what it stops at, and doesn't damage anything else beyond it. And so it really minimizes the chance of causing collateral damage. And the breast sits on the chest wall. So everything underneath it, if the beam were to penetrate any deeper, could hit the heart, could hit the lungs, and even at different angles that we're trying to use with regular radiation to try to minimize that, there's still going to be more exposure to those tissues with regular radiation than you would ever get with protons. And that's going to be critically important, especially on the left side where the heart is closest to the chest.
So the heart is not in the middle of your chest?
No, it's more towards the left.
Okay. So and again, imagine I'm a patient here. So I went to a facility and they told me, well, they're going to do this fancy technique where I hold my breath. I think it's called deep inspiration breath hold. Right. And that's going to keep the radiation from hitting the heart. Doesn't that do the same thing? Doesn't that accomplish the same thing as what you're talking about with proton therapy?
It's trying to. It's trying to expand the lung to try to push the chest wall further away from the heart. And that is sometimes successful in minimizing the dose, but then now you're expanding the lung into the area that we're going to treat, even if you're using angles on that. So yes, it can improve the heart dose, but it doesn't change the lung dose so much. And with protons, we can do that either with that approach, which can enhance our ability to shield out the heart from the treatment field, or we can do it without it very safely. So in that type of situation, we have both modalities at our facility. We have regular radiation and the protons. We can actually do a comparative plan between the two to really look at the difference, to see if the difference is worthwhile to using protons over regular radiation. Typically, when it's on the left side, it is.
So it sounds like if I could dumb this down a little bit, with protons, you kind of get the best of both worlds, where you get the physical benefit of proton radiation being able to be stopped inside the tumor. And on top of that, if we need to, we can also have you hold your breath during treatment if that keeps the heart even more out of the field.
Correct.
So you get the best of both worlds.
Yep.
So we have a late-breaking question from our producer. And I think this is a great question because we get this from patients a lot. Is protons radiation? So we've talked about radiation and we've talked about proton therapy. Are those the same thing, or what's the difference between the two?
Yeah, protons are a form of radiation. So simple answer is yes. Protons and photons are radiation. It's just the different physical characteristics of what they do in the body, right? So with protons, we can stop them. With photons, it's just beam of energy passing through. So when we talk about which one we would use, right? The difference is not usually whether one's going to be more effective in killing the cancer over the other, because both are equally effective from that standpoint, is are we going to gain a significant advantage in protecting our normal tissues in the body? And so we can actually run simulations, right? People do simulations all the time of different things that could possibly happen, right? So what we do is we set up a treatment with protons, we set up a treatment with regular radiation, we compare them side by side to see how much dose is getting to the cancer and how much are we able to minimize dose to the normal tissues. And the one that basically does best with that is usually what's treated or what's used to be treated. Typically, protons are never going to be inferior to the photons or the regular radiation. It's going to be at least equal. And when it's better, then we utilize protons in that situation.
So you have the ability as a doctor to quickly put together a plan or a treatment using proton therapy and assess that against a plan using photon radiation. So it's proton radiation and photon radiation. And you can look at both of those plans and say, which one gets all of the radiation to the tumor that we need, but then also keeps as much radiation off of healthy tissue as possible.
Correct.
And then you'll say, patient, this is the best way to go for you.
Right.
So then I'm a patient and I say, and imagine I'm a breast cancer patient. Well, how many treatments am I going to get?
Right. So that is something that has been studied pretty extensively now, because the goal has been in the most recent, I would say 5 to 10 years, of trying to get the treatment done a little bit quicker, to, number one, have obviously less downtime for the patient to have to come back and forth for treatment, but also to maximize the time away from any treatment, right? So we're trying to shorten the number of treatments by increasing the dose per treatment. And we've done the studies to look at what achieves that maximum effect, basically. Still, the concern always was that if we turn up the radiation dose every day, are we going to get more side effects? And with a very focused treatment like protons, the chance is that we're not going to worsen the side effects profile, but still improve the chance of being cured.
So it's, give me an example of a number of treatments that a patient may get. What's the range, the shortest possible treatment and the longest possible treatment?
Yeah, so the studies that have been done recently, it used to be traditionally, most women would get about 6 to 7 weeks of radiation every day, Monday through Friday. So anywhere from 30 to 35 treatments. We're able to probably starting about maybe 15 years ago, shorten that down to roughly about 15 to 20 treatments. The most recent studies that came out of the UK recently have shortened it down to like 5 treatments. there are different parameters in each of those studies that we have to be careful of, in shortening the number of treatments, how aggressive the cancer is, the extent of the area that we have to treat. Those are parameters we have to look at in order to make a determination as to what is the safest approach. Typically, what we would say that is kind of the standard of care now is roughly about 15 to 20 treatments. And there are some scenarios where we can do 5 treatments. So we would basically, I would say to patients, talk with your oncologist, ask them what number of treatments is the best approach for their cancer, and have them explain to you why, as to safety versus aggressiveness of the cancer, extent of the cancer. Why is it that they're suggesting one number versus another?
And so I just want to step back a little bit on, so we've talked about the number of treatments. If I could summarize, with proton radiation, what we're really trying to do is get most of that radiation to the tumor. Mm-hmm. And it sounds like what you're saying is that critical structure, one of the most critical structures that we're looking at is the heart.
Right.
Tell me a little bit about the dose or the amount of radiation that we're talking about. So I'll give you an example. Mm-hmm. I went to the dentist recently and I got a dental x-ray and I had to wear a lead shield or a lead apron. Right. And the dental tech walked out of the room and they did the x-ray and it seemed like, okay, well, that's probably a lot of radiation. How does that compare to the amount of radiation that we're having to deliver to kill cancer cells?
Yeah, it's on the scale, it's probably 10 to 100 times more when we're using radiation to kill cancer cells. Now, the caveat to that is it's a much more focused radiation as opposed to an x-ray that you're just doing for the teeth or something like that, or chest x-ray, things like that. So it's much more focused. With protons, we can focus that even more. And so what we've talked about in trying to limit the number of treatments, using a very focused treatment like protons, because we're focusing much more and limiting the exposure to other tissues, we can then even further increase the dose that we give every time because there's less chance of damaging everything else, to try to be more successful at curing the cancer with less treatments, and even sometimes even escalating that dose a little bit to improve our chances of cure for some of those cancers.
But that dose that you're talking about, I heard you say 10 to 100 times. So if that dose does spill over to the heart, you're talking about pretty significant complications potentially down the road.
Right. And really the important aspect of what we look at for heart dose is really the heart arteries that are very close to the surface. So the heart sitting underneath your ribs and your lungs is basically a structure that almost looks like a football, basically, right? And on the surface is the arteries or the blood vessels that supply the heart. And that's what's actually closest to where the ribs are. And if you're exposing even a little dose to those arteries, that's enough to kind of scar them down to the point where the circulation is not getting to your heart muscles very well. So the studies that were done back 2013, actually, New England Journal articles showed that even just a little dose, probably a 1/100th of the dose that you give to the breast for the cancer, that dose already translates to almost 10% increase in your risk of heart-related damage 5 to 8 years later. Yeah. So if you think about that and you really expose that blood vessel, then your risk can be upwards of 20 to 30%. And so that's what we started to see in a lot of breast cancer patients. We used to think that any dose was safe, and as long as we kind of come in at an angle and really kind of skim the heart. But what we didn't realize is when we're skimming the heart, that skimming is right along those blood vessels, and that blood vessel translates, that damage to that blood vessel translates into heart-related issues, increased chance of shortness of breath, chest pains, and heart attacks. Probably that's the biggest thing down the road. So that's why it's so critical in breast cancer patients to protect the heart.
It's imperative to protect the heart. It's imperative to keep that dose off the heart. And protons a lot of times are the best way to do that.
Yeah.
And then I think I've heard, and again, I'm putting myself in the shoes of a patient. I think the chemotherapy drugs that patients take for breast cancer can be cardiotoxic. They can actually cause heart complications. And so then when you layer on top of that any type of radiation dose, that can really exacerbate any heart issues.
Yeah, definitely. So there are chemotherapy drugs, and also there are some receptor hormone type of medications that increase your cardiac risk just on their own. And so if you add radiation on top of that, it really kind of magnifies the whole issue with possible cardiac or heart damage.
So, so that I think that's a great summary. Got to keep radiation off the heart. Know what your heart dose is as a patient, and be sure to check out all of your options. Yeah. So I'm a patient, and I say, what can I be doing to maximize my chance of all of these different treatments working? Are there things that I have control over?
I think that probably the biggest thing is to advocate for yourself, to talk to your doctors, to ask them questions about, what they're looking at when they talk about treatment and what the possible downsides of treatments are. So that is probably the strongest message I would have to patients is, don't ever take anything for face value. Ask them the rationale so that you can fully understand. For me, when I talk to patients, I always talk about the fact that I want them to have as much time to ask me questions as possible. Mm-hmm. And I want to give them all the information possible, because that also takes some of the anxiety out of the whole diagnosis of cancer. When you take away the fear, then they can be their own advocates and understand what the best approach is.
What do you think about things like diet and exercise and mental health? How does that play into cancer cure or cancer survival?
Yeah. I mean, the nutrition aspect of it, I'm not a huge believer in fad diets or certain diets that can help. I think having a very balanced diet is very important. I think activity is very important, exercise. All those things have been linked to mind and body, right? So things when you are very physically active also help with your mind frame or your mindset. And all those things will help you in the recovery aspect of it. So yes, I always talk about, never stay stagnant. When your body will tell you when you need to rest, but the times when you're not needing that, then don't be sitting on the couch and, just and being, kind of lethargic.
Which is good advice anyways,
right.
But it almost is more important when you're going through something like cancer treatment. I had a patient recently that I talked to, and she talked about being right at the kind of nadir, the worst part of the chemotherapy. And her goal was, I'm going to get up and I'm going to walk around the living room table, and then I'm going to go back to bed. But she made that goal every single day. And for that worst part, those worst couple weeks, that was her goal. Like you talked about, don't be sedentary, do what you can.
Right.
And that's so important. And it helped her mental health too, just having that goal and then accomplishing that goal each day.
Yeah. No, and there was actually a study, because I treat a lot of kids, there was a study that was kind of pivotal in helping kind of explain how to recover after treatments, and especially because there is a fair number, probably the second most common type of malignancy in children, the number one being leukemia, but or kind of hematologic type of cancers. The second most common type of cancers in kids is really solid tumors of the brain. And so with kids, when we're treating them, what they found is they actually did a study on activity, exercise, things like that. So 20 to 30 minutes of solid exercise, focused activity for 3 times a week for children who have gone through brain tumor treatments help them preserve their IQ better than those who were basically stagnant and basically not doing. So they actually showed that actually improved their school functioning ability, memory, those type of things. They kind of tested them with actual concrete tests, and they found that activity helps with the mind and body. So it's basically mind and body are very well connected.
Yeah, that's amazing. That's really the encouragement. If you say, what can I be doing, doctor? Mm-hmm. Eat healthy, but really also exercise as much as you can. How do I know that the cancer is gone? Do you see it disappear during treatment?
Yeah, so that is always a difficult question to answer, especially because different tumors respond, different cancers respond in many different ways. Many cancers, basically, as we treat them with radiation or other modalities like chemotherapy and things like that, they sometimes will shrink, but they don't always disappear. And I was kind of, probably my best analogy is think about a grape that turns into a raisin. It shrivels, it dries out, it likely is dead as far as how we follow it, and then we do scans and things like that. But it may never completely disappear, but as long as it's kind of just dead tissue and scar tissue, it may look like there's still something there, but as long as it's not growing, it's obviously not a problem. There are certain scans that look for activity. Mm-hmm. And so those are the scans that sometimes we use to try to see if, what's left over still has any activity to it. And in those type of situations, if there is still some activity or some concern about activity, then we talk to a surgeon about maybe just removing that to see if there's anything left.
So when you say there are some scans, are you talking about PET scans?
Yeah, PET scans are metabolic scans. There are other different types of metabolic scans that can be done as well. Different types of cancers have different ways that show their metabolic activity. So it's not always just a PET scan, but in that similar type of vein.
So a lot of breast cancer patients get a genetic test as part of the treatment regimen or deciding how to treat ahead of time. If I'm a breast cancer patient, am I going to get a different treatment based on the results of that genetic scan?
They can. So some genetic testing can show that they are either susceptible to another breast cancer sometime down the road, or sometimes they could be susceptible to another cancer in different parts of the body. Breast cancer can be associated with ovarian cancer sometimes with certain genetic factors. And so if that's the case, there are sometimes for certain patients, if they have a very strong genetic pattern that could make them more vulnerable to that, they may have surgeries to not only remove their breasts, but also remove their ovaries or uterus or those type of things, gynecologic structures that could be at risk with certain type of genetic predispositions.
And that's based on the genetic test that's a blood draw?
Yeah, that's a blood draw.
Okay.
Yeah.
So if I go through all of this treatment and I get surgery and I get chemotherapy and I get radiation and I do hormone therapy and the cancer comes back 2 or 3 or 4 years down the road, then what are my options?
Yeah, it's very individualized because it depends on if it's the cancer that was originally there, because there can be, if there's been at least a 5-year gap from the time that you had your other cancer to the new one, it could be a brand new cancer. So we always test the cancer to see if it's very similar to what you had before. Also, depending on where it's coming back at, if it's in the same location, if it's in a different part of the body, we have to kind of tailor the treatment based on that. There are different ways and different approaches, and it's like kind of coming up with a new strategy again. Again, the surgeon, the medical oncologist, the radiation oncologist usually come together to kind of talk about what was done before and what can be done now. And so again, it's basically just going through the same process of looking at options with all the different specialists.
Okay, that's really helpful. So I think what I'm hearing you say is that there are options down the road.
Yeah. It's never a dead end.
Yeah.
And we just have to look at the whole picture and decide what can be done next.
So this is a question that we get a lot. And I know it's a hard one to answer. What is the cure rate for breast cancer?
Yeah, and that is a difficult question because it is based a lot on the extent of the cancer, what the patient was able to get from the standpoint of treatment. So it is highly dependent on a lot of tiers to what the parameters of the tumor are. So it can be in the very early stages, well above 95%. And obviously, depending on how extensive it is, it drops from there and how aggressive it is. So it can be very highly curable, as with many cancers, if you catch it early.
So it's stage dependent,
Yeah,
is what you're saying.
Yeah.
So what's the role of screening in this process for you as an oncologist? How important is screening, especially let's maybe stay on the topic of breast cancer screening?
Mm-hmm. Yeah, it's critically important because the earlier you catch any cancer gives us options as far as what to do for treatment. And on top of that, the treatments are more effective when there's less cancer to deal with.
So I want to shift gears a little bit. We've talked about breast cancer quite a bit, another cancer that we treat a lot of. And part of this is just the fact of that there is a lot of this cancer is prostate cancer. Mm-hmm. So what's the role of proton therapy with prostate cancer? Yeah,
so prostate cancer has many different options for patients. The traditional one is surgery, right? And then you have radiation seeding, and then you have external radiation, of which protons is one type, and then photons or regular radiation is the other. So protons are just one tool we have to help take care of this cancer. Now, when we talk about level of invasiveness of the treatments, surgery would be obviously number one. The seed implantation would be a little bit less invasive. And then external radiation with either regular radiation or protons is the least invasive, right? So there are different ways to kind of approach things, and patients have different, kind of conceptions about how they want to approach their cancer. So proton's role in prostate cancer is the one of least invasive treatment with the least amount of collateral radiation exposure, which means the least side effects, right? So that's where its role is. And so if a patient is looking for a treatment that is just as effective as surgery, just as effective as seed implantation, sometimes even more effective for, the aggressive nature of the cancer, then protons plays that role. And it can play that role with the least amount of collateral damage.
And so when you say effective, what do you mean by effective?
Like the chance of being cured of your prostate cancer can be upwards of 90 to 95% or better. So if you catch it early enough, and that goes back to screening. And for prostate cancer, we check our PSAs. And if we can catch the cancer at a very early stage, then treatment with any of the modalities can be above 95%, especially with protons, and with its least invasive nature and less collateral damage, can be the least impactful negatively on the quality of life.
When you treat prostate cancer with protons, are you treating the whole prostate?
You are. So when we talk about treating prostate cancer, traditionally, surgery removes the entire prostate.
Okay.
When we put the seeds in, we put seeds in over the entire prostate. So when we treat it with external radiation, we treat the entire prostate. And so with protons, we treat the entire prostate.
And how do you know that the cancer is gone? So I'm done with treatment. When and how do I know that cancer is gone?
Yeah, the PSA is actually the only true test of any cancer that can be very specific to that cancer, so that it's actually a great surrogate in knowing how much cancer there is or the possibility that the cancer is gone. So the PSA after we're done should drop very close to zero. So basically below 1 to 0 is where we expect the prostate PSA after we're done for it to be fully gone.
So you mentioned seeds.
Uh-huh.
What do you mean by that?
Okay. So radiation can be given internally for prostate cancer. And the way we do that is with these tiny radioactive pellets that we put into the prostate that can last anywhere from a month to 3 months, giving off radiation internally. So it's giving radiation from the inside out. And these little radiation seeds, these little radiation pellets, basically emanate radiation from inside. It's such a low level of radiation that really there's not a lot of radiation going outside the body. but it's just more focused on putting radiation right where the source is. It's something called brachytherapy.
Okay.
So brachytherapy, that term comes from the Greek word that talks about proximity. So it's basically using radiation in proximity to the tumor so that we're placing it either next to the tumor or inside the tumor. And so for prostate cancer, we're putting it inside the tumor. It's something that has been traditionally done for years and years. We do it at the center, at the Proton Center. We have that capability to do it. And for patients who have low-grade, localized disease, it's actually kind of a nice way to take care of prostate cancer because it's one time and you're done, right? It's kind of like surgery, but it's not as invasive as surgery. It doesn't have the same side effects as surgery. It's much easier to kind of do. And for lower grade cancers and localized cancers, it can be just as successful as any of the other modalities.
So one thing that I've heard is that if you're younger, you should get surgery, and if you're older, you should get radiation. Is that true?
Well, so really the reason or rationale behind that really is that patients who are younger recover and heal much better than older patients, just because the tissues come together easier. So when you do surgery and remove the prostate, the healing that has to happen afterwards really is key to being able to retain your ability to control urination afterwards, the leakage factor, basically. And so as patients get older and you remove that prostate and reconnect the bladder to the urinary tract or reconnect the plumbing, you kind of lose the valve that helps control the urination. And if you lose that and you don't have good healing of the tissue, you could have to wear a pad or diaper for the rest of your life. And that's a huge quality of life issue.
Yep.
So that's why in patients who are younger, if surgery is what they want to do, and usually it's the patient who has the mentality of, I have a cancer inside of me, I need to get it removed. They're the ones who are going to go that route. Now, from the standpoint of effectiveness, whether the patient's 40 or 80, radiation can be just as effective.
Right.
So younger patients can still get radiation. They can still get protons. They can still get seeds. But from the standpoint of surgery, the patients who are younger are going to do better with surgery than the patients who are older. So typically, even the surgeons don't like to do surgery on patients who are 70 or older, just because they don't want to have to, really deal with the patients having incontinence and complaining.
It can be a more challenging recovery as you get
Most
older.
Definitely.
Yeah. So, but that's a good point, though. I think I like what you said. And in our last episode, we actually talked about treating pediatric patients with proton therapy. There's no age constraint on being eligible for proton therapy or benefiting from the fact that proton is the most targeted, most precise form of radiation that we have available today as within the radiation oncology community.
Correct.
So to wrap up, just a couple more questions. What are some other types of cancer that benefit from proton therapy, or how would I know as a patient whether or not proton therapy would be a good option?
Right. Just as a quick kind of overview of what, the way I think about it is, protons is a beam that basically is able to be kind of focused and honed in on a target and have less collateral damage. So if you think about it that way, anything in the body, any tumor in the body that's close to a critical structure would benefit from protons, right? And basically anything from head to toe, unless it's on your leg or your extremities, anything basically in the torso and your head would benefit from proton therapy. All right. So we've seen the studies now, and there's more data really coming out very soon, that head and neck cancers would benefit from proton therapy because we're not going to damage the swallowing muscles as much, or the vocal cords, or because some of the cancers are close to the brain, we can minimize any chance of damage to the brain. So head and neck cancers would benefit from proton therapy. We've actually seen the data showing that there's less chance of needing a feeding tube with head and neck cancer when you treat it with protons as opposed to regular radiation. With esophageal cancer, so your swallowing tube from basically your neck on through to the stomach, there's been a randomized study that showed a significant advantage in the chance of severe side effects when you're using chemo and radiation for esophageal cancer, which all esophageal cancers typically need. We're seeing now with anything in the upper abdomen, your liver, your pancreas, that's close to critical structures. We've seen benefit in that situation as well. So basically, anything in the body that's close to a normal tissue, and like I said, head, neck, your whole torso, those are the areas that would benefit. The best thing to do is talk to your doctors and ask them whether they think proton therapy would be something that would be helpful in their situation. And if they don't know, then reach out to a radiation facility that has protons to be able to kind of speak to that.
Well, and I think that's a good point, is that the field is evolving so rapidly, and there may be cancers that we didn't treat with protons 5 or 10 years ago because we hadn't developed the techniques or the protocols or the planning software hadn't evolved enough to be able to treat that particular disease site. And so it's going to be a doctor that's regularly using proton therapy that's going to be most knowledgeable about what types of cancers could benefit from proton therapy. Mm-hmm. And that's why it's important to talk to someone like you who has access, who does brachytherapy, who does proton therapy, who does traditional photon radiation, and as we talked about in the last episode, really works collaboratively with medical oncologists and surgical oncologists to decide how that treatment fits in this entire treatment regimen for patients. Because as we talked about, it's all about maximizing the quality of life while also maximizing the cure.
Right.
More than just a cure, also the quality of life. Last question for you. A patient walks in and they say, isn't radiation bad? Like, I've heard that radiation is bad. Why am I getting radiation for my cancer?
Well, it is bad, but we want to make it bad for the cancer cells, mm-hmm. right? And so that is, again, kind of back onto the kind of the drive of what we're trying to do, is that we're using this beam, which is bad for cells, to try to target only the cancer cells and not the normal cells. And so yes, radiation can be bad. It destroys things, mm-hmm. right? But our goal is to use it to destroy the cancer cells and to miss all the normal things so that we can improve the chance of the patient beating the cancer.
Well, that's great. I really appreciate the way that you put that. So radiation is toxic to cells, but we're going to focus that toxicity. We're going to focus the killing power of radiation on cancer cells while preserving the healthy tissues. Yep. Well, I really appreciate your time, Dr. Chang. And thank you for everybody who had joined us for this episode of the Cancer Project. As always, subscribe. We're on multiple channels, YouTube, Spotify. If you have questions, leave them in the comments. If you do have questions about a particular cancer diagnosis for yourself or a loved one, and you want to talk to a doctor, talk to somebody like Dr. Chang, feel free to reach out to us at the Oklahoma Proton Center. And again, thank you for joining us.